What's up, Ninja Nerds? In this video today, we're going to be talking about cystic kidney disease. This is part of our clinical medicine section. I really hope that you guys are liking these videos and learning a lot from them. If you guys like them, please support us. You can do that by hitting the like button, commenting down in the comment section, or subscribing. Also, I really suggest this. Go down in the description box below, click on the link that goes to our website. On our website, we have a lot to offer if you become a premium member. Besides the videos, you can access notes, illustrations, quiz questions, case series, so much more, and we even have courses that we're developing. So go check that out if you guys want. All right, let's start talking about cystic kidney disease. All right, my friends, so we're going to start off talking about cystic kidney disease. When we talk about these, there's a couple different types. One is simple renal cysts. These are actually pretty common. They're actually oftentimes incidental findings. We find them during imaging of a patient getting a CT scan or ultrasound for some other reason, and you happen to just meander upon that. This is usually with simple cysts, the way that we define them pathophysiologically is that usually they are a thin-walled sac. So I'd say that they are a thin-walled sac. And then when we talk about this thin-walled sac here, oftentimes when you look at this on ultrasound, it's usually fluid-filled and it's very dark. And so we'll kind of represent this with this bluish color here. And so we'd say it's a fluid-filled sac that when you look under ultrasound, it appears what we call anechoic. And that means that it just really appears dark on imaging. Now, this thin-walled sac that is anechoic on ultrasound, so we'll say anechoic on imaging, the reason why that this usually actually happens is very interesting. Oftentimes, the most common cause is increasing age. So as people get older, there's many different kind of concepts behind this, but for some reason, maybe they develop an obstruction, some type of obstruction within their actual tubular system. And within this obstruction, right, here's their obstruction, let's say, this will cause a back pressure to build up proximal to where this obstruction is. When that happens, the back pressure will start causing kind of like a kind of exertional force on the tubular wall. And what will happen is this will cause that bulging of the tubular epithelium, right? And that is what leads to this cyst formation. So this is what kind of stimulates, if you will, the cyst formation. And then again, it gets filled up with a bunch of fluid. So that's the concept that I want you guys to understand, is that usually there's some degree of an obstruction. Usually this is with increasing age that causes this cyst formation to occur. All right? Complex cysts are a little bit more ominous. And what we look for with this one is usually it's very thick-walled. So it's a thick-walled sac. So whenever you look at this puppy versus this thin little guy. This definitely has a thick-walled sac. The other components of it here is that when you look here, you see how there's like these like little things that are bridging down here, like here, here, here. This is called septations. Sometimes we even refer to this as multilocular. So it also has lots of septations. The more septations, the more complex the cyst is. And then sometimes, when we look at this, it may even have some calcifications to it. And I'll represent that with these like blue dots here. So that may even represent calcifications. So if you see a very thick-walled cyst with septations and calcification, this is really concerning, and it makes the cyst no longer a simple one, but more of a complicated one. The question that you have to ask yourself is, why is it important to be able to differentiate these? And oftentimes this also has a lot of solid material in it. This one is anechoic. Usually this one is what's called heterogeneous. It has different colors on imaging. And so that's really, really important. But the real complex component here with complex cysts is that these are usually a concerning feature for malignancy. So oftentimes the biggest concern is malignancy. And the most common type of renal cell tumor that we get kind of scared about is what's called renal cell carcinoma, RCC. There is other reasons you can get complex cysts. It doesn't have to be malignancy, but this is the biggest concern with complex renal cysts. It can happen due to infection of a cyst or hemorrhage into a cyst. So that could be other causes, but it's not the one that we're really thinking about, especially for exams, and on top of that, for the wards. The big thing here is that sometimes you can have a tumor in here. So you could have a renal cell carcinoma, and that's making up some of the solid material. And that can also lead to this septation and the calcifications. The biggest concern, and what you have to look for with complex renal cysts, is that whenever you look at these cysts, there is lots and lots and lots of blood flow to these cysts, especially if there's risk of malignancy. And so why is that important? When we do what's called contrast imaging, what it will do is you'll do a CT scan of the abdomen. If there's heavy vascular flow to this cyst, you'll cause enhancement of that actual cyst. And so that's the big thing is contrast imaging. If it's a really bad cyst and you're concerned about this having a potential chance of being malignant, you'll see what's called contrast enhancement. And all that's telling me is that I have a pretty good vascular supply. I have a pretty good vascular supply to this actual cyst. And that's a concerning feature that we have to be aware of. So whenever you do contrast imaging and you're looking at this cyst, if you see enhancement of it, it definitely tells me that this has a potential for being malignant. All right? Now, the next component here that we have to talk about is polycystic kidney disease. Now, in patients who have cysts, you can have a couple different simple renal cysts. You can have a couple different complex renal cysts. But what we get really concerned about is if you have multiple cysts in both kidneys and they're just everywhere. So what I look for more specifically to tell me about polycystic kidney disease versus multiple simple or complex cysts is I look for bilateral enlarged kidneys. So bilateral enlarged kidneys and multiple cysts in both of those kidneys. So when you look at these puppies, look at the size of these honkers versus these. So you got big old kidneys, and on top of that, they have multiple cysts in both kidneys. That is a telltale sign that I'm talking about polycystic kidney disease. Now, with polycystic kidney disease, the thing that you have to start asking yourself is if I see a patient who has bilaterally enlarged kidneys with multiple cysts, is this autosomal dominant or autosomal recessive? So with autosomal dominant polycystic kidney disease, usually, pathophysiologically, you start off with like a heterozygous mutation. And then over time, it's almost all patients, they develop what's called a second hit phenomenon. And they have what's called 100% penetrance of that mutation. And they have both copies that become mutated. All right. What is this gene that we're concerned about? Well, it depends. There is two, but one of them is that there could be a mutation in what's called the PKD1 gene, which we see on chromosome number 16, all right? So this is the big one. This is actually the one that occurs early in life, and on top of that has a very severe course. So that's one thing I would remember is that this is a really common one, probably the most common one, and I would say it has an early onset, so it starts early on in life, and it causes severe manifestations, all right? There is another mutation. It's the less common one, but usually it's the same concept. You can cause a mutation in what's called, and this one actually makes it kind of easy, in the PKD2, so PKD2 gene. And this is on chromosome number 4. This one usually comes with a late onset and it's less severe. All right, so this one's the less common one, but it is important to remember this for some questions that may come up on your exam. All right, now, what's the big deal with this? All right, let me explain. If you have a mutation, this is going to be the more common one. This would be the less common one, but there's a mutation in this gene. Do you know what these genes encode for? They encode for proteins. So PKD2-1 and PKD2 encode for what's called polycystins. So there's what's called polycystin 1 and polycystin 2. So polycystin 1 is usually encoded for by PKD1. So we have what's called polycystin 1. And then you have what's called polycystin 2. Now, what's the benefit of knowing these? These are usually proteins that, let's say the polycystin 1 is the light blue colored one, and polycystin 2 is this pink colored one. What they do is they bind into what's called, they kind of form the component of the cilia. So this is going to be, we're going to say that this is the cilia. All right. On the cilia, you have these polycystin proteins, and what they are supposed to do is control calcium entry into the cell, which plays a role in cell-to-cell signaling and cell proliferation. Now, imagine you have a mutation in these. What's going to happen if you have a mutation in this one? You're going to have absent polycystin 1 and absence in polycystin 2. So if there is a mutation here, a mutation in PKD1 or a mutation in PKD2, you have absent proteins. Will you have these proteins on the cilia? No. If they're not there, guess what they're supposed to do? Normally, what they're supposed to do is as urine flows across this is a tubular epithelial cell. So imagine all I'm doing is I'm taking a piece of this nephron right here. Imagine it's right here. I'm taking a piece of it and I'm zooming on one cell there. As urine flows across, it bends the cilia. And what's supposed to happen is it's supposed to control calcium entry. And calcium, what it's supposed to do is it's supposed to inhibit cell proliferation. All right, so that's what it's supposed to do, is it's supposed to inhibit cell proliferation. But you need these to be present in order for that to occur. You need these proteins to be present. If these are not present, guess what you will not be doing? You will not be bringing calcium into the cell. If you don't bring calcium into the cell, you aren't able to allow for normal cell signaling mechanisms. And guess what you're going to do? You're going to, instead of inhibiting cell proliferation, you're going to increase cell proliferation. Now as these cells start proliferating, oh baby, look at this. All these tubular epithelial cells go ham. As they go ham and you stimulate the cell proliferation, you're going to start forming these sacs, if you will. So imagine that's just this thing, and I'm looking at the epithelium that's lining that sac, all right? So you're going to start forming these sacs, all right? Is going to be these epithelial cells, if you will, that are kind of lining them. Then, well, you know what else you're going to do? There's a hormone. There's a hormone. It's called ADH. ADH in patients who have polycystic kidney disease tends to be overexpressed. There's multiple mechanisms. This could be genetics. This could also just be due to overactivation of the renin, angiotensin, aldosterone system. Either way, it's overexpressed. There's receptors that are present on these tubular epithelial cells. And you know what they're supposed to do? They're supposed to control these red proteins. You know what these red proteins are? Aquaporins. These are called aquaporins. You know what aquaporins are supposed to do? They're supposed to control water movement out of the cell. Now, if ADH is present, what it's going to do is it's going to bind onto this epithelium and it's going to stimulate the production of water in this sac of epithelial cells. And now what's going to happen is I'm going to fill this sac with a bunch of water. And what am I going to form? I'm going to form these things all over the nephron. So then you start causing cyst formation. This stimulates your cyst formation. So cyst formation is due to a ciliopathy, if you will, which means mutation in genes that leads to decreased expression of these proteins that are important in the cilia. You lose calcium signaling. Calcium's supposed to inhibit cell proliferation. If you don't have calcium going in, you cause the cells to proliferate, form these epithelial sacs. Let me just actually rephrase that. These are epithelial sacs. It's an easier way of remembering it. Epithelial sacs. That's going to form. Then ADH is usually overexpressed in these patients for some reason. So in patients who have polycystic kidney disease, for some reason, they have an increased expression of ADH. That stimulates aquaporin expression, so I'll have more aquaporins, and I'll produce more water into this epithelial sac, which will lead to the cysts all over the nephron. That's pretty straightforward. And then over time, if this continues to happen, over and over and over again with time. So again, with time, increasing time as patients get older and older, they form more cysts, more cysts, more cysts, and this is what's going to happen over time. They're going to have cysts all over their kidneys. That's autosomal dominant. Oftentimes, with autosomal dominant, the biggest thing that you need to remember is that this appears in adulthood. Okay? It's usually young adults. The other one is autosomal recessive polycystic kidney disease. This one is in infants. So this is really, really sad one, and we'll talk about this more in the pediatric section, but this is going to be in infants. So young little babies, and sometimes even in utero, which is even worse. Their cause is they have a mutation, and it's going to involve kind of both alleles, and you're going to have a mutation here in a very specific gene, and this is called, it's actually thankfully not far off, mutation in what's called KHD1. And this is going to be present on chromosome number 6. Now, what happens here is, if you have this mutation, this is going to lead to the, you know what this codes for? It codes for fibrocystin. So what's going to happen is if you have a mutation here, you're going to have a absence in a very particular protein called fibrocystin. We do not know as much about this protein as we do about these. What we think, and this is all I'm going to keep it to because I don't want you guys to memorize things that isn't completely known, it's more theory, is we think it plays some kind of role with that same concept within the cilia. That maybe it co-localizes with these proteins, maybe it's involved in some other kind of signaling mechanism, but we do know that in some way it plays a role with the cilia, and it's supposed to control, in some way, shape, or form, calcium signaling. And so if you have an absence of fibrocystin, you won't allow for the calcium signaling mechanisms. If you don't allow for the calcium signaling mechanisms, guess what's going to happen? You're not going to be able to inhibit cell proliferation. What's going to happen if you don't inhibit cell proliferation? You're going to cause proliferation to occur. Same thing exactly exists. You have overexpression of ADH, increased production of aquaporins. When you make all these epithelial sacs, you fill them with water and form cysts all over. These patients over time will develop polycystic kidney disease. That's the difference between the two. The only other thing to remember though, polycystin is expressed in multiple other tissues, not just the kidneys. It can be expressed all over the places. And this is where a lot of complications come in, a lot of what's called extrarenal cysts, all right? Fibrocystin is really important because this one is important in the babies, particularly their liver and biliary system. So it plays a very, very, very important role in their liver and biliary system development. And so as patients experience disease here, what you'll start to notice is the absence of fibrocystin can increase the risk of something called hepatic fibrosis. And we'll get into this as we get into the complications. But that's the important thing. Fibrocystin is important in other things besides the tubular epithelium in the kidneys. Polycystin is important besides the tubular epithelium in the kidneys. So if we understand that, we'll then be able to say, oh, I see now why patients have other extra-renal complications. Now that we've covered these, let's now go into what are the classic findings that we see with cystic kidney disease. All right, so when we talk about cystic kidney disease, we now know the different types, we know the pathophysiology, we know the causes. I think it's important to know how these patients oftentimes present. Funny enough, simple renal cysts, like I said, they're incidental findings. They usually don't present with any symptoms. So they're oftentimes asymptomatic. It's the complex renal cysts and the polycystic kidney disease that have very kind of oftentimes a trajectory of findings that should make us start thinking about this disease. So another concept is with patients who have polycystic kidney disease, most patients will have a family history because there has to be some type of genetic component here. So oftentimes look for that in the vignette. Look for a patient who has an underlying family history of polycystic kidney disease or has experienced one of the complications similar to that. But oftentimes these are the three most common complications for cystic kidney disease. It's hematuria, flank pain, and a palpable mass. The hematuria could be a couple different reasons. I'd say one reason is that the cyst ruptures. And when the cyst ruptures, let's say any of these cysts begin to rupture, that can cause nearby blood vessels. So oftentimes there's like nearby kind of like scraggling blood vessels that are nearby that can cause these to basically empty some of the blood into these collecting systems, into this tubular system. And so oftentimes we see this as the result of cyst rupture. So hematuria is a pretty common cause, and we see in patients who have polycystic kidney disease, oftentimes the most common reason is a patient has cyst rupture that triggers this particular process. So I'd say that's the most common reason. It could be other related complications. Patients who have polycystic kidney disease are at high risk of having especially nephrolithiasis. So that could be one. But I'd say oftentimes hematuria, we can see this in both. We can see it in complex renal cysts, and we can see this, I'd say, in more so autosomal dominant polycystic kidney disease. All right. Now, the big thing about this hematuria that is really important to remember is that the hematuria that these patients have, usually when you look at it under what's called a urinalysis, so if you do a urinalysis, it'll have no significant presence. So usually the UA is negative for red blood cell CAS. Usually the UA is negative for any kinds of like infection. And what do I mean? Usually there's not going to be any leukocyte esterase. There's not going to be any kind of nitrites or excessive bacteria. If that is the case, that's more likely of a UTI. And also, the reason why this is important because it helps out in the differential, because patients who have hematuria, one of the big things that you always want to rule out, is it an infection or is it glomerulonephritis? And then from there, if you've ruled out that it's those, and then there's no underlying kind of coagulopathy, you get imaging. And you look to see, do they have nephrolithiasis? Do they have a tumor? Do they have some type of cyst that potentially are the cause? And so that's what you kind of go through in that process. All right? So just remember that as a big thing here. Flank pain is another really common feature. And this can be tough because patients can also present like this with other causes. Maybe they have a tumor. Maybe they have nephrolithiasis. And so you have to be thinking about alternative reasons. The most often reason is because they have, and again, we can see this in patients who have, again, complex cysts. And I'd say more so, we see this in complex cysts, and we see this in the autosomal dominant polycystic kidney disease. The reason for this is just you're kind of stretching of the renal capsule. So if you stretch that renal capsule, that's heavily innervated, which we're going to represent here in the pink. That stretching of the renal capsule is going to activate nerves that are going to cause that referred pain, that flank pain. That's oftentimes as there's an increased stretch of the renal capsule due to these cysts. They're pushing on that area. Other reasons that you can have flank pain, especially in polycystic kidney disease, so more so in the polycystic kidney disease, the ADPKD, is it could be due to everything we talked about over here. Maybe they ruptured a cyst, or maybe it's not a cyst rupture. So let's say one of them could be due to a cyst rupture. That definitely can cause pain and that can cause hematuria. But also, let's say that I have an infection. So let's say there's a bunch of bacteria in here and it's causing inflammation and infection of this cyst. We see this a lot in patients with polycystic kidney disease. They have frequent urinary tract infections because they have stasis. This is an area of stasis. And so having an increased risk of what's called cyst infection, which we can see in these patients pretty commonly, can cause the flank pain. And another one is stones. So let's say that I have here a renal stone. Whenever you have stasis, stasis also increases the risk of a lot of these sediment or urinary concentration molecules, especially calcium and oxalates and things like that, to increase the risk of stone formation. So they also can have what's called nephrolithiasis. And this may also contribute to the patient's flank pain. So they're at increased risk of cyst infection, increased risk of stone formation, and cyst rupture can also precipitate these patients' flank pain. But I'd say the easiest one is just you have these enlarged cysts compressing on that renal capsule. The last one is a palpable mass. And again, we can see this actually, funny enough, in all of them. So you can see this in the complex cysts. You can see this in autosomal dominant polycystic kidney disease. And oftentimes this is the biggest feature that we see in autosomal recessive polycystic kidney disease. When we look at these patients, usually if they have a complex renal cyst, this is usually oftentimes, more likely than not, since it's a high risk of malignancy, it's usually one-sided that we would feel this. But if it's polycystic kidney disease, so this is your complex, this is the complex cyst, these are oftentimes, more than not, one-sided. The autosomal dominant, the autosomal dominant polycystic kidney disease and autosomal recessive polycystic kidney disease are usually bilateral, palpable masses. And so that's the big thing that I would want you guys to remember for this. All right, oftentimes more than not, if it's polycystic, it's going to be bilateral. If it's complex renal cyst, it's usually one-sided. And so that's one way that you can kind of think about the classic findings. All right, so say I have a patient come in, they're presenting with flank pain, they're presenting with hematuria, they're presenting with one-sided, so let's just say in this case, left-sided palpable mass. I'm thinking about a complex renal cyst, all right, especially if they have a history of smoking, if they have some type of underlying concerns for increased risk of malignancy. In that scenario, I want to look for other features that make me think about renal cell carcinoma as a potential complication of a complex renal cyst. Because remember, I told you that's one of the big causes. So what do I look for? Well, I look for that triad that we just talked about. I look for hematuria. I look for flank pain. And then I look for, lastly, a palpable mass. If I see these three things in combination with what's called paraneoplastic syndrome, I definitely am starting to think about renal cell carcinoma, and then I just need imaging to confirm. So one of them is hypercalcemia. So the concept here is that these tumor cells, they gain the capacity to make hormones. And what they do is they make a very specific hormone that we talked about in the calcium disorders, and this is called PTHRP. So PTHRP is a parathyroid hormone-related peptide, and what that does is that acts on the bones, and that also acts over here on the kidney tubules. And what it does is it increases osteoclast activity, which helps to rip calcium from the bone, and then causes calcium reabsorption at the distal tubule. And either way, what you're going to do is you're going to start causing a patient to have high calcium. And so the ways that they often may manifest with high calcium is increased risk of kidney stones, increased risk of bone pain and lytic lesions. They also may increase the risk of nephrogenic diabetes insipidus. They may also have potential abdominal pain and constipation, and they may even have neuropsychiatric disturbances and even EKG changes like a shortened QT interval. So these are things to be thinking about on that vignette. The other thing is polycythemia. I would say that this is a really big one. If a patient comes in with polycythemia in combination with the RCC triad, definitely be thinking about this could be a manifestation of a complex renal cyst. Oftentimes here, this malignant-like tissue is increasing the expression of a very important hormone, and this hormone is called erythropoietin. We also can abbreviate this EPO. EPO is supposed to go and work on our bone marrow, especially the red bone marrow, and increase the synthesis of red blood cells. And so guess what's going to start happening, my friends? You're going to start pumping out these red blood cells. And you're going to have more red blood cells than you normally have. And so this is going to cause an increase in the number of red blood cells, which will be oftentimes represented via an increased hemoglobin, an increased hematocrit, an increased red cell number. And these are also patients who are more high risk for a hyper kind of viscosity state, so they're at high risk for strokes, etc. The last one is also really high yield. In these patients, these tumors gain the capacity to potentially increase the production of renin. And if they increase their production of renin, this could be due to the tumor itself, or it could be due to compression of renal vessels within the renal parenchyma. It's going to increase the production of renin because it's going to perceive it as though there's reduced blood flow to a nephron, or it's just due to the tumor itself gaining that capacity. That increased renin is going to lead to increased angiotensin 1, increased angiotensin 2, and that's going to lead to the patient having a very, very high blood pressure. And so hypertension is very, very common here, and this is something that you want to look at. So if a patient has high blood pressure, polycythemia, hypercalcemia, plus a triad, and lastly, imaging, cyst on imaging or some type of mass, let's say mass or complex cyst on imaging, this is enough for me to really start having a very strong suspicion of renal cell carcinoma. All right, as a relationship of it being a complication of complex renal cyst. Because again, complex renal cyst, the most common cause, is usually malignancy, with other ones being infection and potentially hemorrhage into the cyst. All right, now the last thing that we have to talk about here is how do we now talk about the complications of autosomal dominant polycystic kidney disease, and what would that look like? All right, so if a patient comes in now, and now they're saying, hey, I'm having some flank pain, I'm having on top of that some hematuria, some blood in my urine, and maybe you're examining them and you feel a palpable mass. You're starting to think, okay, this is a cystic kidney disease of sorts. Maybe they don't have a lot of the risk factors for what you think is a complex renal cyst, right? But you're still kind of trying to figure out what are some things that are making me think that this could be. I think one big thing is that, complex renal cysts with the chances of malignancy, you're going to see that in older patients. Patients who have adult, kind of what we used to call adult onset polycystic kidney disease or autosomal dominant polycystic kidney disease, you're going to see this in younger adults. And so oftentimes what will happen is usually around like their 30s, around that time frame, they'll come in with a couple different complications that you want to look out for. One is chronic kidney disease. This is pretty common. So as you see here, we have these cysts. Now, for this diagram, for purposes of the actual illustration, what happens is these cysts are so large that what they do is they start to compress nearby structures. So imagine over on this side there's a nephron, and then over here maybe there's another nephron. I'm just using this as an example that this is a cyst compressing its own blood supply, but it could be compressing other blood supply going to a neighboring nephron. If you have this cyst right here, what it's doing is it's compressing the renal vessels. So this cyst right here, this little SOB right here is compressing, it's smashing down onto this renal blood vessel. The problem with this is that blood is supposed to be delivered through here, and now it's got to try to trickle through here to get to the actual glomerulus, filter things off, as well as go to the efferent arteriole and supply all the oxygen to other tissues. All right? Now, if I have this cyst that is compressing here, I'm going to have what's called renal blood flow. There's going to be a reduction in the renal blood flow. That reduction in renal blood flow is going to start causing ischemia to the nephron. So now I'm going to have ischemia to the nephron. As I start to cause ischemia to the nephron, this nephron is going to start losing its function. So now what I'm going to do is I'm going to start causing red X's here to show now parts of this nephron is diseased. It's not functioning. It undergoes necrosis and it dies. It becomes fibrotic over time. It stops working. As I have ischemia to nephrons over time, what this does is this leads to loss of nephrons. With a decreased nephron number, you then lose the function of the kidneys. As I lose the function of the kidneys, what's going to happen? I'm going to have a diseased kidney. This thing is going to start becoming less functional at being able to do what it's supposed to do, which is clear waste products. And so what's going to happen is I'm going to start seeing the patient's creatinine start to climb over time, and I'm going to see their GFR start to decrease over time. And so these are going to be parameters that as you're following this young adult, you're going to see an abnormal finding here of an increase in their creatinine and a decrease in their GFR over time. And then the biggest concern with this is that you're losing the ability to clear waste products. So potassium can start to go up. What's that called? Hyperkalemia. So I would be worried about hyperkalemia and the manifestations that could arise there, such as arrhythmias. I'd be worried about the buildup of acid. So there may be a buildup of protons or a decrease in the amount of bicarb, and so you're at high risk for acidosis. Or there may be a buildup in sodium in water, but more so water retention, because you're losing the ability to kind of excrete free water. This can cause hypervolemia, which can manifest with edema, hypertension, hyponatremia, etc. But the biggest concern over time is uremia. So as you increase your BUN, you increase the risk of things like pericarditis, encephalopathy, platelet dysfunction with bleeding, immune dysfunction, etc. These are all things that can happen to a patient as they progress towards end-stage renal disease, which is oftentimes very, very common with polycystic kidney disease. Oftentimes with these patients, they will progress and they will start to experience end-stage renal disease, and they'll need dialysis or a transplant to survive. So this is a really big thing, is that the cyst is causing problems. As they get older, you get more cysts. More cysts compress more renal vessels, cause more ischemia to the actual kidney, cause more nephron death, and lead to worsening renal function. So the biggest thing here to remember is, with increased cysts comes increased death, or what I particularly say, worsening chronic kidney disease. So increased cysts increases the end-stage renal disease progression. I think that's the best way of saying it, is with increased cysts, you cause increased end-stage renal disease progression. So that's what we have to think about here. Another big complication with these patients is hypertension. And so finding a young, adult or kind of someone in their 20s or something like that coming in with high blood pressure, flank pain, hematuria, and palpable masses with damaged kidneys is kind of odd, right? That would be making me think about a secondary hypertension, and renal vascular hypertension is the most common cause of secondary hypertension. Same concept here. The cysts are really the problem. So the cysts are compressing neighboring nephrons, but in this particular diagram, they're compressing the renal vessels. So now I have renal blood flow moving through here. So this is that cyst, and it's compressing on this puppy. So look at it just smashing down here. Now as the blood flow goes through here, there's going to be less blood running into the glomerulus. You remember these cells here? There's some little cells that right here at that JG kind of juxtaglomerular apparatus. What are these cells? The JG cells. The JG cells increase the expression of a molecule called renin, right? And so these JG cells will pump out more renin. Renin will lead to an increase in angiotensin 1 and an increase in angiotensin 2. And then with the increase in this, you're going to start causing your vessels to start constricting with angiotensin 2, right? So it causes increased systemic vascular resistance. If you remember, just kind of imagine here, I'm just squeezing the vessel. That's all it's really doing. It's just binding onto receptors and squeezing the heck out of these vessels. And so it's causing an increase in systemic vascular resistance. And that's going to pump up your blood pressure because you're having more resistance to blood flow. So BP will start to go up in these patients. All right, and that's kind of odd in a young person, right? The other concept here is angiotensin 2 also increases the production and expression of ADH. And remember, ADH worsens cyst growth, which can worsen hypertension and worsen end-stage renal disease. But it also increases the expression of aldosterone. What do these two combos lead to? ADH, you retain water. Aldosterone, you retain sodium. So you're going to get an increase in sodium and water retention, and that's going to pump up that blood volume. And as you pump up the blood volume, you're going to start pumping up your blood pressure. And so this is the ways that these patients can develop high blood pressures. The RAS activation is very, very intense. All right. Now, here's the thing. These are big presentations here in a patient with autosomal dominant polycystic kidney disease. So look for the triad plus these two. Other things that may help in the diagnosis is this: extrarenal cysts. So remember I told you polycystins, they're important in a lot of connective tissue development. And so they play a role in connective tissue all over the body. One of them is in the liver and the pancreas. And so you can get cysts that occur there, and these are called hepatic cysts, and these are called pancreatic cysts. All right, hepatic cysts and pancreatic cysts. And it's the same concept. All you're doing is causing replication of the epithelium in that tissue with increased expression of aquaporins, and you cause fluid-filled sacs to form within these organs. Funny enough, though, these are usually benign. So most of the time, more than not, these are benign, and you just find them on imaging. And I think that is what's really, really important to remember, is it's a benign finding. These don't really cause any kind of true cirrhosis or pancreatitis. More often than not, it's usually a benign finding, and you'll see it on imaging. And so that just helps in assisting with the diagnosis. It doesn't do much else beyond that. You can have other extrarenal manifestations besides these. For example, you can see things like mitral valve prolapse because it causes weakening of the connective tissue in the mitral valve. In the chordae tendineae, and so that can get kind of weak, and you can develop some mitral valve prolapse there. And you can even develop because of weakness in the connective tissue around the valve. And you can even see it in diverticulosis as well. But I'd say that this is a really big one to think about if you see this on imaging. All right, sometimes they can ask you, they can say, hey, you have a patient with autosomal dominant, or they kind of present with an autosomal dominant polycystic kidney disease picture, and you say, you get an ultrasound of their abdomen, what are the suspected findings that you may see that support the diagnosis? And that would be these hepatic and pancreatic cysts. They can even occur in the seminal vesicles as well, but this is the big ones. The other thing I think is actually interesting, because you will see this on the exam, where you have a patient who's kind of a young adult, hypertension, some chronic kidney disease, and then they have a history of frequent urinary tract infections or frequent nephrolithiasis. The concept behind this is actually kind of cool. So you have these cysts, and these cysts are basically a site of stasis. Okay, so this is basically every one of these cysts is a site of where you can have a stasis of urine flow, right? So that's one reason. If you have stasis of urine flow, all right, or urinary filtrate, this is going to cause things to, colonize there. So one really big thing to remember is when you have this stasis, this is going to increase the risk of bacterial growth and stone formation. So it increases the risk of bacterial growth and stone formation. And that, I think that's really the simplest thing. I also like to think about it like this too, because this is what also causes problems. Is imagine here you have your kidneys, and here's all your kind of collecting system here. So you have your calyces, and then it kind of dumps in eventually into your renal pelvis and then into the ureter. These cysts, they grow and they start compressing on things. And so imagine here I'm compressing on this area, and I compress on this area, and I compress on this area. As I compress on these, I can't allow for urine to flow in its normal direction. It's supposed to flow in this direction, but you're basically blocking it by compressing on that system. And so that also is going to cause that stasis of urine flow. So you have the cysts themselves that can cause stasis of urinary filtrate, but also the cysts are compressing other collecting systems. And so that's another thing to remember here, is that these cysts compress your normal renal collecting system. And that also is going to lead to this stasis of urine flow. It becomes a breeding ground for bacteria to replicate because they're not flowing in one direction out into the toilet bowl, and then stones can also form pretty easily. And so you want to watch out for a frequent UTIs. Usually this is more upper urinary tract, so pyelonephritis, and frequent nephrolithiasis. And so these are the big things that I would think also is really important to see about in the vignettes. So look for a patient, young, hypertension, chronic kidney disease, frequent UTIs, frequent nephrolithiasis, maybe have some benign findings on their imaging like hepatic and pancreatic cysts. The last thing that I really want to focus on is really an important thing. This could be a cause of mortality in the patient. So this could kill the patient. In combination with CKD, this is the biggest one, but this is one that could kill the patient. Remember I told you it's a connective tissue problem. So polycystins play a role in the tubular epithelium, but it also plays a role in connective tissue development. And connective tissue in our blood vessels is critical. So oftentimes these patients can have what's called intracranial aneurysms. And so for example, here would be like an MCA, so a middle cerebral artery aneurysm. This is a pretty bad one. Over here, I'll have what's called a posterior communicating artery aneurysm. And then over here, we can have what's called an anterior communicating artery, ACOM, aneurysm. These can form as a result of weakening of the connective tissue within the vessel wall because of a polycystin mutation. The problem with this is that if these puppies rupture, so if this thing just, oh my gosh, could you imagine? If this thing ruptures, you're going to increase the risk of what? A subarachnoid hemorrhage. So the most fearful complication of this is that these have a very, very high risk of rupturing and causing what's called a subarachnoid hemorrhage. So these patients, we'll talk about this more in the neuro section, but more of the emphasis on this is identifying patients who have polycystic kidney disease and preventing them from having subarachnoid hemorrhages. So one of the biggest risk factors for this is actually if the patient has a family history. So we see the highest incidence, high incidence, if there is a family history. And what do I mean? A family history of intracranial aneurysm or a family history of a ruptured aneurysm like a subarachnoid hemorrhage. And so we don't want a patient to get to this point where they have headaches, they have nausea, vomiting, they have increased intracranial pressure, neurodeficits, etc. We want to prevent that. And so in patients who have polycystic kidney disease, it is of crucial importance to ask them, has you ever had any family history within your mother or father of an aneurysm in their head or a subarachnoid hemorrhage? Because if they have, they need to get surveillance. And that's the significance of this. All right, we talked about this. Let's move on to autosomal recessive. On to autosomal recessive. So we have this young infant, and this is really going to be kind of the takeaway whenever you see a vignette of sorts where you're like, okay, I don't know if it's autosomal recessive versus dominant. It's usually going to be an infant. And you're going to see an infant presenting with chronic kidney disease, so impaired renal function with maybe complications related to it, hypertension. That's not normal. And so think about these things. So the concept behind there is exactly the same as we talked about in autosomal dominant. You got this cyst here that is compressing your renal vessels. It's compressing all kinds of renal vessels, neighboring nephrons, their own nephrons, but it's compressing these renal vessels. Blood flow is supposed to be running through this. This is renal blood flow. What happens is the renal blood flow, as it runs through the kind of afferent arterial system and then trying to squeeze past this little area where the cyst is compressing, it's supposed to run here, filter some things off, leave out through the efferent arterial, and then do what? Go and deliver oxygen to all other parts of the nephron. If I have the cyst compressing this, my renal blood flow is going to be reduced because the cyst is reducing the amount of blood flow getting through here. If I do that, I'm going to then stimulate the ischemia, right? Because this is supposed to supply oxygen to all these tissues. Now what's going to happen? Oh, I'm going to jack it all up. Now I'm going to cause ischemia. I'm not going to deliver as much oxygen and nutrients to the nephron. Whenever this occurs, the nephrons begin to die. So then I lose nephrons. Why is that important? Well, we already talked about it. As there is a decrease in nephrons, you lose the structural and functional unit of the kidney. All of this stops working. You lose the ability for filtration. You lose the ability for reabsorption and secretion and all of these things. And so because of that, your kidney function is going to start to decline. And these patients oftentimes develop end-stage renal disease. Now, the problem with end-stage renal disease here is that this can represent with lab findings, or this can represent with complications of the actual chronic kidney disease. What could this be? Well, one thing is that the labs could suggest that a patient has an increase in the creatinine, right? Which is kind of a marker of poor renal function, but a bigger one, especially for chronic disease, is a GFR. And so watch for the reduction in the GFR over time, watch for that bump in the creatinine, and this is kind of a telltale sign. But the scary way is if a patient presents with complications related to their chronic kidney disease. This is what you want to be careful of. Does the patient have an increase in potassium, an increase in protons, an increase in sodium and water, an increase in the BUN? So what would that be called? If they have an increase in the potassium, they can develop hyperkalemia. This can oftentimes manifest with EKG changes. Are they presenting with a lot of protons in the bloodstream, precipitating a acidosis, a metabolic acidosis? That could be another thing that you want to be watching out for. The next one is an increase in sodium and water retention. What would that be? Well, if they're retaining a lot of that, their volume in the body can go up and they can develop something called hypervolemia. So they can have edema, hypertension, hyponatremia. And then lastly, is their BUN going up to the point where they're starting to have complications, such as pericarditis, encephalopathy, your platelet dysfunction causing bleeding, then you're thinking about uremia. So the biggest thing to remember here is that these patients oftentimes, they develop end-stage renal disease very, very early in life. With this is a similar kind of mechanism. So in patients who have hypertension, these are young children having hypertension. You got to figure out why. It's because these cysts, same thing, compress the renal vessels. That's going to reduce the renal blood flow through the kidneys. So now my renal blood flow, I got to try to run this stuff through here. Look at this. Whoop. Look at this. I'm reducing my renal blood flow here. I'm reducing my filtration. There's little cells, son of a gun, little cells here called juxtaglomerular cells, and they sense the blood flow and the pressure. And when the renal blood flow is reduced because of these cysts that are just mashing on these renal vessels, what's going to happen? They're going to sense that and say, oh, got to kind of bump up the blood pressure. And so what it does is it increases the production of renin. Renin then converts angiotensinogen into angiotensin 1. Angiotensin 1 gets converted into angiotensin 2. Angiotensin 2 then goes and binds onto these blood vessels and constricts them like a son of a gun, like you can see in this diagram. Their resistance goes up and the blood pressure goes up, right? So this cascade, if you will, is super characteristic of the renin-angiotensin-aldosterone system. Because this is really the big thing, is it's going to squeeze these vessels. The resistance, the flow is going to go up. And we know the equation that blood pressure is equal to cardiac output times resistance. But you know what else it does? It pumps up your ADH and your aldosterone. And what do these do? They cause you to go into sodium and water retainers. So you retain sodium and you retain water, which causes your blood volume to go up, and that will then cause the blood pressure to go up. And so that's the concept here, is angiotensin 2 can really amp up this pathway of ADH and aldosterone, retains water, retains sodium, pump up the blood volume, and pump up the blood pressure. Seeing this in a young infant is not normal in combination with renal disease. But you know what else is even not normal? Is if the baby also has not just renal disease with hypertension, but coexisting liver disease. That's like a telltale sign that it's likely ARPKD. So if I see a patient with end-stage renal disease, hypertension, and portal hypertension, something's not right. There's a good chance they have this disease. Let me explain why. In this disease, one of the big proteins we say ARPKD is fibrocystin. So fibrocystin is a protein that is important in the renal tubular epithelium, but it's also important in the liver tissue. And so what happens is, when there's an absence of fibrocystin, for some reason the stellate cells or whatever happens here, they start causing a lot of fibrosis. And when you have fibrosis of this little baby liver, it's called congenital hepatic fibrosis. This takes this poor little baby liver, which is so sad, and causes it to become super fibrotic. Let's represent that here with pink. So now I'm going to take all this pink tissue here, and I'm going to start causing fibrosis all over this poor little baby's liver. And what it's going to do is it's going to kind of start mashing down on all this hepatic portal venous vasculature. All right? When it mashes on it, imagine I'm trying to run blood through the actual liver, and it's a little highway system. It's getting clogged here. So blood will try to run its way here, but it'll just back up. All right? It'll back up. And so what happens is this causes the pressure in this portal system to go up. So you develop what's called portal hypertension. This causes blood to back up from the portal veins into the splenic vein, the mesenteric veins, the esophageal veins, and you develop complications. One is it can cause blood to back up into the esophageal veins, and you get these things called esophageal varices. These things rupture, oh my gosh. And it's a terrifying thing to see, and these patients can really get sick and die. If these rupture, they can cause an upper GI bleed. All right, pretty terrifying. Another one is if it backs up into the splenic vein, and the spleen starts getting kind of filled up with blood, this can cause splenomegaly. The problem with splenomegaly is that this can cause sequestration of platelets. And if platelets get sequestered and get taken away, this can cause thrombocytopenia. And then the last thing is if the pressure backs up into the peritoneal capillaries and causes fluid to accumulate here into the abdomen. Look, you got a big old belly here, a protuberant abdomen. This is called ascites. The concern with all of this is that in patients who have these real big fluid-filled abdomens is what? Well, it can cause a protuberant abdomen. It can cause it to become very distended. But another thing is, with all of these diseases like ascites, it increases the risk of what's called spontaneous bacterial peritonitis. Esophageal varices, we already said, increases the risk of upper GI bleeding. And splenomegaly increases the risk of thrombocytopenia. And so I think that's what's really important to remember is a patient with coexisting liver disease with features of portal hypertension plus end-stage renal disease in an infant. With that being said, this is oftentimes the most common reason that these patients die. And usually it's at the birth process. It's kind of interesting in the mechanism, but it's overall is sad, that these patients develop disease of their kidneys because of these multiple cysts. And so oftentimes they experience what's called in utero renal failure. So they develop chronic kidney disease in utero. The problem with this is that because of this, they develop less urine output because the kidneys are supposed to be responsible for making urine. If you have chronic kidney disease, not only do you have increased creatinine, increased BUN, increased potassium, all these other things, but it also leads to less urine production. And these patients experience something called oliguria. Now, the baby's urine, which may sound disgusting, is also important for making amniotic fluid. And so what happens is when you have this oliguria because of chronic kidney disease, this leads to less amniotic fluid formation. So now take here this blue. This is supposed to represent all the amniotic fluid. I'm not going to make as much of this amniotic fluid. You know what we call that? We call that oligohydramnios. So this leads to something called oligohydramnios, which is basically a decreased amount of amniotic fluid. Now, when you have oligohydramnios, you don't have as much fluid. And what happens is this starts to squeeze on the poor little baby. And when you squeeze on the baby, it leads to some developmental abnormalities. Oftentimes the triad that we like to remember to make it easier for us on our exams is it causes craniofacial abnormalities. And there's a bunch of them. The second one is club feet. It kind of smashes on the little, poor little baby's legs and can cause clubbed feet. The one that oftentimes kills the patient is the amniotic fluid also plays a role in the development of the lungs, and they don't develop properly. And you don't develop enough alveoli and bronchi, and so this can cause pulmonary hypoplasia, which is underdeveloped lungs. This pulmonary hypoplasia, the problem with this, if I have underdeveloped lungs, I have less alveoli. I have less bronchial trees. The problem with this is the ability for gas exchange becomes significantly impaired. If I don't have enough alveoli, if I don't have enough bronchial trees to conduct and then allow for exchange of gases, this impaired gas exchange is going to lead to, so this decreased gas exchange is going to lead to respiratory failure because it's going to cause like a VQ mismatch. That decrease in gas exchange is what leads to respiratory failure. And this is oftentimes the way that these patients usually die. So how could that respiratory failure look? Well, when they're born, they could develop hypoxia, so a decrease in O2. They could develop a bluish discoloration, especially of their limbs and of their lips, which is called cyanosis. They could develop an increased work of breathing. What the heck does that mean, Zach? That means that they're breathing faster, they're using their poor little bellies, they're using their nose and flaring them. So these are all signs of respiratory distress, and oftentimes what has to happen is these patients usually need to be intubated to help them to be able to survive this. But this is important to remember, this is the most common cause of death in patients with ARPKD. So on that unfortunately sad note that covers the pathophysiology and the complications of cystic kidney disease, we now need to kind of become very good diagnosticians and say, how do I truly systematically approach, differentiate these, and come up with a good diagnosis, and then how do I manage this? Let's do that next.
We talked a lot about the different types of cystic kidney disease, being able to talk about the patho, how to differentiate them, some of the mutations that are involved in some of the genetic ones. And then we went over the classic findings, what you would see in simple, which is not much, what you would see in complex, and what you would see potentially in the polycystic kidney disease. And we talked a lot about the complications. What I want to do is put all of that together now and come up with an approach. So if you see a vignette, how do I really kind of look at this and analyze this scenario? So first thing, for a patient who you say has maybe some flank pain, maybe some hematuria, maybe they even have a palpable mass, it's always a good idea to get a renal ultrasound. If you get the renal ultrasound and it tends to show like a thin-walled cyst, anechoic in the center, what does that sound like? It sounds like a simple renal cyst. If I see this one, and this is oftentimes what you'll see in the actual, the exam, is they'll show a patient who comes in, they end up getting an imaging, and what happens is they show you a picture here and say, what's the next step? What do you do? And oftentimes it's nothing. You just reassure them that it's okay, nothing's wrong, and you don't need to do anything else. All right. So you're going to look for this very thin-walled, very nice circular and dark center type of structure that would suggest a simple renal cyst. Now, if I looked at this other one and I say it's like, it looks thick-walled, it's got septations in it, it's calcified, I'm thinking about complex. And so this is what you'll see. You'll see how this cyst here, it's thick-walled, it's got all these septations in it. It does appear to not have as much of a heterogeneous color, but this is very concerning. But I would say with this one, I got a thick wall, I got septations, I have a little bit of heterogeneity here, but I'd say with this one, I'm definitely concerned and I want to be on the alert for malignancy like a renal cell carcinoma. So with that being said, oftentimes the best thing to do when you find a complex renal cyst is to get a better picture. And that's where a CT scan comes in. So you can kind of see this one. This definitely looks like heterogeneous. You can see the septations are all present here. You can see it's very thick-walled. It's huge, definitely greater than 3 centimeters. So I have a very, very high concern for malignancy in this patient. And so it's really important to know this. What you may see a question on the exam is determining the Bosniak classification. But what I want you to know is more focusing on using the Bosniak for the treatment. But let's quickly talk about this. It's really determining the risk of malignancy. That's what I want to know. And so, for example, if I see it and it looks like it's a very thin-walled type of cyst, it doesn't enhance, which means it doesn't have a lot of vascular supply, and I'm not really concerned for malignancy, that's a low chance of malignancy. That's probably just a simple renal cyst, and I don't really need to do anything about it. If it's a little septated, but again, it doesn't enhance, then again, I'm not as concerned, and I would still say that I probably don't need to have any follow-up for this patient. If it's a little bit bigger, it's a little bit thicker walled though, and I do see some septa in it, I'd be a little bit more concerned that I may have a follow-up imaging maybe in a couple months or a year. If I look and I see this thing as thick as heck, right, and I see that it appears irregular, right, and it does start to begin enhancing, I'm a little bit more concerned in this patient, and I may need to actually go in and do like a nephrectomy, maybe a partial nephrectomy. If I look and it appears that it's very clear and solid and it appears like it's a cystic appearing mass and it's enhancing, I'm very scared and I may need to go in and do a nephrectomy as well. And then that's kind of the ways that I would judge a patient on their Bosniak classification. So again, it's really important to remember that usually oftentimes 1 and 2, it's not as concerning. All right, these are the ones that I would probably go ahead and say we don't need to do anything about. We can just reassure the patient and they don't need to get any follow-up imaging. When I get to 2F, even though there's no enhancement, because of the size and the thickness of the walls, I'm going to say let's get a follow-up imaging in a couple months just to be safe. But when I see enhancement, irregular appearance, lots of septations, it's big, it's got thick walls, I really need to get in there and potentially remove this cyst. And so it may be a partial or a complete nephrectomy in 3 and 4. All right, and we'll talk about that a little bit later. So the next step here is once we've determined, okay, it's a simple or a complex. For complex, again, the big thing I want you to know, 1 and 2, not bad, can probably just send them home. 2F, 3, and 4, these are a little bit more concerning. 2F, got to get a follow-up imaging. 3, 4, I probably need to go in and actually take a piece of it out, send it off to pathology, and just be safe. All right? We haven't found the polycystic. So what if I say, okay, I got bilaterally enlarged kidneys, and I'm going to test your knowledge here. The cysts are multiple different sizes. That was autosomal dominant likely, right? But if I say that I got bilaterally enlarged kidneys and the cysts appear to be at least the same size, it suggests more of an autosomal recessive. But this isn't enough. What I really want is the presence of bilaterally enlarged kidneys with multiple cysts and classic findings or complications that more likely highlight that disease. So that's where a good history and physical exam will come into play. Again, looking here, you're going to see, look, there's like tons and tons of cysts on this ultrasound. So that's going to be the diagnostic test of choice. So if they say, what's the diagnostic test of choice for potentially a polycystic kidney disease patient, you should say a renal ultrasound. Now, when I look at this patient, again, I need to say, okay, what really highlights autosomal dominant and what really highlights autosomal recessive? Well, for the autosomal dominant patient, they're usually older. They're an adult. They're not like an infant or in utero. They usually have that classic presentation, which is the flank pain, hematuria, and the palpable mass. They usually have hypertension, end-stage renal disease, as well as, what's the other one in the brain? The intracranial aneurysms that are concerning. And sometimes on other imaging, if you happen to get lucky and get some abdominal imaging, you may see extra renal cysts, such as hepatic cysts, as you can see some here. And you can't see the pancreas here as well, but there'll be pancreatic cysts that present as well. With a child or in utero, I'm thinking more about autosomal recessive, especially if I see those palpable masses in the infant. And again, complications that highlight this one is going to be the pulmonary hypoplasia, that they'll present with significant respiratory distress, usually in birth, end-stage renal disease, and the congenital hepatic fibrosis, which leads to portal hypertension. Now, with this being said, we've made our diagnoses of the specific type of cystic kidney disease. The next step here is how do we treat each one? For simple, you do nothing. All right, it's fine. Just tell them, hey, you're good. No need to worry. It's an incidental finding. Nothing concerning about it. All right. The next step, though, is if I start to get to a patient who has a complex renal cyst. Because in simple renal cysts, again, we can use the Bosniak classification to a degree in the sense that it'll be thin-walled, it'll be round, it'll be anechoic in appearance. It will not enhance because there's no excessive vascular supply here. So their chance of malignancy is very low. So you don't need to do anything. With the 2, right, as we start getting a couple septa in there, it is a little bit more concerning, but again, the chances of it having malignancy are still pretty low. So do I need to do anything? No. Where it starts to get a little bit more complicated is when that starts to branch into the 2F. As this thing gets bigger, thicker walled, it's got septa. It still doesn't enhance, but I'm still concerned, oh, there is a chance of malignancy. If there is a chance of malignancy, I should probably go ahead and get a follow-up imaging in maybe 6 months to a year. If I see 3, so that means it's now getting irregular. It's no longer round. It's irregular in appearance, and it's got lots of septa. It's got thick walls. In this particular scenario, and it enhances, I have a high risk, all right, of me having a malignancy here. I definitely need to go in there and take that piece of cyst out. So I need to consider surgery to do a nephrectomy. If I see that it's really big, it's got a lot of heterogeneous material, it's cystic appearing, and then I see on top of that that there is a lot of enhancement, I'm definitely concerned for malignancy. And again, I'm going to go in and do a nephrectomy. All right. So the way I want you to think about complex renal cysts is you'll treat 2F with follow-up imaging. You'll treat 3 and 4 with nephrectomies. Okay. What about ADPKD? Well, believe it or not, we got to treat the complications of the disease oftentimes. And so sometimes one of the highlighting drugs that we'll use is ACE inhibitors or ARBs, angiotensin receptor blockers. The main 2 indications for it is for the effect that it has on our high blood pressure, and the other one is the protein that can be lost in the urine. So believe it or not, when you think about these, we know that these patients tend to have higher RAS activation, right? That's because their GFR tends to start creeping down because of compression of the renal vasculature. So they pump up their renin, right? That leads to a lot of angiotensin 1 and then angiotensin 2. But if you give an ACE inhibitor an ARB, what are you doing? You're blocking the conversion or the function of angiotensin 2. ACE inhibitors will block the conversion and ARBs will block the effect of angiotensin 2. So effectively, you'll reduce the efficacy or reduce the presence of angiotensin II. That means what? I don't squeeze the vessels as hard, so I end up with a normal blood pressure, or the blood pressure at least goes down. I don't activate ADH and aldosterone, so I don't retain as much sodium and water, so I don't have as much expansion of my blood volume, so my blood pressure should also normalize and come down. So that's the mechanism of this. But it also can be used in proteinuria. So we know that in CKD, albuminuria, proteinuria specifically, that tends to portend a poor prognosis. That is, as there's high amounts of albumin that's being lost, it leads to more cardiovascular dysfunction. And so we want to prevent that. We want to have a renal protective effect. So when you give it ACE inhibitors or ARBs, they again effectively reduce the action of angiotensin II. Angiotensin II not only acts in this way, but it also squeezes the efferent arteriole so that it can actually increase the GFR. But we don't want to do that, because if we increase the GFR, we increase the pressure in the glomerulus and pump more proteins out. So what I want to do is I want to dilate that puppy. All right? I don't want it to vasoconstrict, so I want to decrease its constriction and instead cause it to dilate. That'll drop the pressure inside of the glomerulus, and I won't filter as much protein or albumin across the glomerulus, and so that'll reduce the albuminuria. So again, big thing with ACE inhibitors, ARBs, is you always want to watch for hyperkalemia, because this is a potential complication due to the hypoaldo effect. You also want to watch for the increase in creatinine, because it can cause the vasodilation of the efferent arteriole. So it'll drop your pressure in the glomerulus and drop the GFR. So you could see an increase in creatinine via pre-renal AKI. But again, your purpose here is that you're trying to get that blood pressure down, get it to where they're not developing complications due to the hypertension, and on top of that, trying to reduce the albumin that's being lost into the urine. Here's the interesting concept. In ADPKD, I told you that ADH enhances the cystogenesis process. So what if I came up with a drug that could block ADH and then reduce the cystogenesis process? Theoretically, I could decrease the risk of progression. So that's where tolvaptan comes in. So imagine here I have a kidney. I have a patient with polycystic kidney disease, and we're going to follow them throughout their life. What we notice is that their kidneys get bigger and bigger and bigger. So their total kidney volume over time will increase. And this is where you'll start to see, due to the increasing formation of cysts. So this is due to cystogenesis, that we see the TKV, the total kidney volume, go up. Tolvaptan theoretically could decrease the total kidney volume, so it could decrease the progression of cyst formation. That's kind of an interesting concept. And the reason behind this is that tolvaptan is blocking ADH from hitting these ADH receptors. It's blocking the aquaporins from pushing water into the cyst, and therefore decreasing the cyst growth. That's going to decrease the multiple cysts that are forming, which then decrease the size of the kidneys. That could theoretically decrease the progression of CKD. And that's what's really interesting here. So when we actually look at this in a graphical representation, what we've seen with ADH antagonists like tolvaptan is that without tolvaptan, the GFR will tend to go down progressively. Whereas with tolvaptan, it may decrease that progression a little bit. Same thing. If we look at the symptoms that are resulting from this disease, without tolvaptan, they go up. And with tolvaptan, they kind of tend to slowly progress. And then total kidney volume, again, we already talked about. So that's one of the benefits of tolvaptan. The only downside to tolvaptan is it's an ADH antagonist. So they pee a lot. They pee a lot of water, and so they end up with polyuria and polydipsia. That's kind of difficult on a patient who has to go to the bathroom all the time and drink water all the time. The other thing is renal replacement therapy. And again, you're thinking about this in the sense that a patient who has polycystic kidney disease most of the time will progress to CKD. So if their progression really gets bad to where they get to CKD 4 or 5, you may start seeing uremia. You may start seeing refractory acidosis, hyperkalemia, hypervolemia. And so in these scenarios, you're going to try to give them medical management, but you may need to start reaching out as they get to stage 4, or hopefully not too late, but stage 5, reaching out to say, hey, I need to obtain access. Maybe we need to start getting an AV fistula going or an AV graft. And if it's emergent or urgent, we may need to do a central venous catheter. It's important to also consider aneurysm screening. I say aneurysm screening via an MRA, which is looking at that imaging. Again, if they talk about this in the vignette where they have a patient who you have polycystic kidney disease as the likely diagnosis, and they have a family history of a family member who had an aneurysm, or they had a subarachnoid hemorrhage from an aneurysm, you get the MRA. all right, because they're high risk. If they do not have a family member, or they don't have a family member who had this aneurysm or the subarachnoid hemorrhage due to the aneurysm, you don't get the MRA, all right? So that's the point of this, is trying to, again, survey for those patients that are high risk and there's a higher probability. And again, you're doing this to look for the aneurysm so that if you find it, okay, let's reach out to neurosurgery, let's reach out to neurointerventional radiology and consider securing that aneurysm. What about ARPKD? So with this one, it's kind of similar. You give MACE inhibitors, ARBs. Why? To get their blood pressure down, to reduce the proteinuria, to reduce the progression of their CKD and risk of cardiovascular dysfunction. It's the same thing. You're basically blocking angiotensin II. And if you do that, you lead to less vasoconstriction, you lead to less ADH and aldosterone, which leads to less sodium and water retention, and that's going to drop your blood pressure. On top of that, it's going to block angiotensin II from vasoconstricting. And instead, it should vasodilate, which drops the pressure in the glomerulus, which reduces the filtration of albumin into the urine, and you'll have less albuminuria. Again, watch out for the potassium, watch for the creatinine, and again, your overall goal is to get the BP lower, and on top of that, to try to reduce the albumin that's being lost into the urine. Again, ARPKD, some of these patients, if they do happen to survive a little bit later, you may need to consider putting them on dialysis. You may need to start getting an AV fistula or a central venous catheter going to obtain access to start saying, I need to begin dialysis if you're having refractory hyperkalemia, uremia, etc. All right, the next thing is portal hypertension. So this is kind of like a quick recap from what we talked about in GI, in the cirrhosis lecture and in the ascites lecture, where again, you're going to be initiating therapies in this scenario where if a patient has portal hypertension in this disease, you want to give them beta blockers. This wouldn't be a first-line acute treatment. It would be more for long-term prevention. Beta blockers tend to reduce the portal pressures. If they develop esophageal varices, though, that's when you're going to want to go ahead and ligate. So here's our varice. I'm going to go ahead and say, I got to get rid of that puppy. So I may ligate that thing off, all right? And prevent that thing from bleeding and causing massive hematemesis, all right? If they have lots of ascites, I may use diuretics, and the preferred diuretics actually tend to be spironolactone, and I'd say in a 2.5 to 1 ratio, where we give 2.5 of spironolactone to a 1 ratio of furosemide. And then if that's not working effectively, then we may need to do a paracentesis and actually kind of take off that fluid. And sometimes if it gets to be large volume, we may need to supplement albumin. Now, in this scenario, as we've started to drain off some of that fluid, all right, cool, we've treated the ascites. But what if the patient tends to have refractory portal hypertension? So they continue to have esophageal varices, they continue to have ascites, they have complications due to their ascites like SBP, or you do paracentesis and they develop hepatorenal syndrome. They're starting to have lots of problems due to their portal hypertension. That's when I would reach to doing a TIPS. Again, a transjugular intrahepatic portal systemic shunt, where we'll actually go down through the jugular and we'll put a shunt in between this kind of portal vein and the hepatic vein to help to increase the blood flow across this shunt so that we can bypass all these kind of areas where there's fibrosis, compressing those little portal venules. Again, we do this as a way of being able to progress a patient to a transplant, with the end goal is that most of these patients will progress to fulminant liver failure where they're going to need liver transplant. All right. Now, the last thing that I want to talk about here with ARPKD is that a patient who has pulmonary hypoplasia is at risk for massive respiratory distress and respiratory failure. And oftentimes, whenever they're born and they start to exhibit these signs, they oftentimes need to be intubated, unfortunately, so that we can mechanically ventilate them, we can control their oxygen, their CO2, and hopefully give time for their lungs to heal. And so this may be a necessary indication for these patients if they are struggling to breathe. All right, my friends, that was a lot on cystic kidney disease. I really hope that it made sense. I hope that now you can differentiate between these, know what's the complications, what's the pathophys, how to diagnose these, and then on top of that, what's the treatment and why do we initiate this treatment? If you did, awesome. I hope that you guys enjoyed this lecture, learned a lot. Love you, thank you, and as always, until next time.